Assalamu alaikum warahmatullahi wabarakatuh. May the peace, blessing, and mercy of God be upon you. I am Hadir Murshidi, and I am lucky to be with you and to be a part of Policy Advocacy in Genetics and Genomics course. And today, my colleague Mariam Youssef and me, we will present our topic: should there be mandatory genetics and screening of newborns for inherited conditions? Group 4, negative team, represent Egypt. Before commencing the debate, I would like to assert my biotechnology background with a profound interest in genetics and molecular biology. I hold the firm belief that a comprehensive understanding of these disciplines enables effective comprehension and interaction with human cellular components. However, I'm also a proponent of the adage, you must engage your mind to reveal what's hidden. With this principle in mind, I have opted to present the negative aspects of genetic newborn screening. It's imperative to investigate both positive and negative sides in order to enhance your scientific background and scientific understanding. Okay, what's about newborn screening? Newborn screening is a process by which infants are tested for genetic disorder, most of which are considered to be severe with significant morbidity and mortality. The purpose of MPS program is to identify or detect newborn before symptoms manifest disability or death. Newborn screening was launched in 1960 by Dr. Liebert, and it is screened for phenylketonuria or PKU. And in 1968, convention by World Health Organization or WHO tried to develop criteria to assess the value and appropriateness of MPS program, which were modified to try screen for large number of disorder. And especially in 1990, MPS programs were developed to screen large number of disorders, especially metabolic disorder. But we have a problem. MPS expanded slowly and failed to meet the needs of population screening due to obvious limitations, including low efficiency and high false positive and negative results. Also, important purpose on the other hand, it raised several psychosocial and ethical issues. So most of abnormal MPS results turn into false positive, and this point is our constructive argument. Let's start to talk about what our constructive argument entails. Constructive argument is based on several stages of MPS. So we will talk about harms of MPS associated with screening, harms of MPS associated with diagnosis, and finally harms of MPS associated with treatment. But in this presentation, we will talk about MPS associated with screening and diagnosis only. So we will talk about harms of MPS associated with screening, what's physical pain or medical risk, and what is the harm of false positive results and false negative results, and we'll do a case study to make an evidence to our topic or our argument. Harms of MPS diagnosis, like physical pain or medical risk, discrimination, cultural sensitivity, informed consent. And this point we will talk at Mariam in details. First point in our constructive argument is physical and risk associated with screening. MPS or newborn screening depends on dried blood spots, and a blood spot collection process involves a health tech and is not a significant harm because it's considered a routine practice. And as we shown in our timeline for specimen collection, it is a comment. Before going to the next slide, if we screen to metabolic disorder, try to avoid first day of newborn because or to avoid false negative or false positive results. But we try to select our specimen collection, especially fifth or fourth day. It's optimal. As we mentioned previously, dried blood spot is not a harm, but screening for a particular condition requires additional blood or tissue sampling. Pain or medical risk would arise if data collection would include any invasive practice previously not applied routinely to newborn, such as radiation exposure. Okay, second point in our constructive argument is false negative associated with screening. Number one, collecting the screening sample outside of the optimal time window. As we mentioned before in our previous slide, if we screen to metabolic disorder, we should collect our blood specimen optimal in fourth or fifth day to avoid any false negative result or false positive result. Number two, error of collecting sample and handling. Third, clinical intervention prior to sample collecting, transfusion. Fourth, analytic insensitivity, such as cut-off value, because if the result below cut-off value, it will lead to false negative results. Fifth, incorrect interpretation of result or poor genotype-phenotype correlation in newborn, such as newborn may be a carrier or have a silent mutation that will lead to incorrect interpretation results. Supporting our constructive argument, there is case report on false negative results. So, false negative newborn screen for tyrosinemia type 1 or TT1. Tyrosinemia type 1 is a rare inherited metabolic disease of tyrosine, caused by the loss of function of FAH. And to screen tyrosinemia disease, you can, or disorder, you can use tyrosine as a biomarker. And to decrease false negative result, you can use saccharonyl acetone as a biomarker instead of tyrosine. In our case presentation, uh, before 9 years old, the patient was screened for TT1 via SA NPS with negative result. Moreover, because the NPS SA concentration of this patient fell below the Dutch cut-off value. And as we, if you remember, as we mentioned before, cut-off value is one of the reasons that can cause false negative results. So the aim from this case report is creating awareness that TT1 patient can be missed despite a negative SA-TT1 NPS result, depending on the cutoff used. Based on our experience, we advise TT1 to be considered in any patient with otherwise unexplained liver pathology. As we mentioned before, to decrease false negative results, you can use SA as a biomarker for tyrosine to decrease false negative result. And there is another strategy, second tier test strategy, and we can call it confirmatory test. And confirmatory test can be applied if the result be positive and you need to confirm it. So one of the most disadvantage of this strategy is not used as primary screening. It is very cost and take time. Point in our constructive argument, false positive associated with the screening, negative impact in clinical staff, public health screening process in future, parents feeling disappointed and anxiety, um, negative impact the relationship between parent and their children, public perception, parent psychosocial well-being, and perception of the child's health. Continue to support our constructive argument. So there is article on a psychosocial impact of a true positive and false positive or inconclusive newborn blood spot screening result by Dutch National Institute for Public Health and the Environment is responsible for organizing and overseeing the national NBS program. In our this article, the participants was divided into three groups. One of them cases and the other control. Cases was divided into two, abnormal and inconclusive. Abnormal can be divided to um, true positive or TB and false positive or FB, and inconclusive maybe it's called IC and control. And they answered on two questionnaire, T1 and T2. T1 after the result of MBS, and T2 after NBS by 6 months. So as we mentioned, the questionnaire was applied T1 and T2, was covering three main points or three main topics: perception of MBS, psychosocial impact of MBS results, and health utilization. In our study in conclusion, perception of MBS, IC or inconclusive participant has less sufficient knowledge compared to control, as well as TB and FB, true positive and false positive parents, has a lower sufficient knowledge compared to control. And at T1, one FB false positive and one inconclusive participant expressed regret about participating in NBS. And according to psychosocial impact of NBS results, FB and IEC has negative emotions for MBC results, and in at T2, TB and FB participants more negative emotions compared to control, and TB participating higher score on the head and anxiety item. According to healthcare utilization, true positive and false positive participant and inconclusive participant reported more frequent hospital, and false positive and inconclusive participant expressed regret about participating in NBS. Finally, I want to tell you that the most parents uh, suffer from distress and anxiety and disappointed, maybe a loose perception sometimes. All of this because the result of uh, false negative or a true positive or false positive. And anyway, or however, the rate of distress or anxiety can it change from person or from one parent to another. So it is core, it is not for granted. Thank you, and I will let you enjoy with my colleague Mariam Yusuf.
On the other hand, there is a long term psychological impact on children who know they are being monitored for genetic conditions from birth. While early detection of genetic conditions is beneficial, the constant awareness can lead to anxiety and stress. These children might feel vulnerable and different, impacting their mental and emotional well being. Moreover, societal stigmatization can worsen this issue, making it essential to balance early detection with mental health support, and will lead to the need to provide comprehensive support system so we can ensure those children thrive, not only survive. There's also an issue of autonomy and the potential for discrimination in the context of mandatory genetic screening. First, mandatory screening can be seen as a violation of personal and parental autonomy. It takes away the freedom to choose what information is known and shared about one's genetic makeup. Second, there is a fear of genetic discrimination. People worry about being treated unfairly in insurance, employment, and social interactions based on their genetic information, making the balancing of the benefits of early detection with respect for the personal choice and protection against discrimination crucial. In regards to the cultural sensitivity, which is the third important aspect related to the harms associated with diagnosis and screening, genetic diagnosis and screening, there is two important concepts. First, acceptance and trust. Cultural beliefs and historical mistrust in medical systems can lead to resistance against mandatory screening, which makes it crucial to build trust by engaging communities and addressing their concerns respectfully. Second, the respect for diversity. We must take in consideration that honoring and respecting diverse culture perspectives on health, illness, and genetics is important, and this respect ensures that we approach genetic screening in a way that's inclusive and considerate for all cultural backgrounds. As a way to counteract the ethical issues and the security issues, such as the autonomy and the right of choice, informed consent was chosen by the pioneers in genetics in order to inform the patient of every step of the way. But even the informed consent has its downsides. For example, a case that took place in the Arizona State University versus the Havasupai people. The Havasupai tribe members were informed that their genetic material or their genetic data is going to be used for studies of diabetes. But more than they know, it was revealed that the researcher didn't only use it for diabetes, they were also used to screen for schizophrenia. That led to potential stigmatizing of their genetic information without the tribe's explicit consent and violated their privacy and cultural beliefs, which led to great emotional and psychological stress of the Havasupai community, triggering a lot of untrust in the outsiders and raised fears about how their genetic information could be used against them. Regarding the potential for discrimination, there are some concerns for long-term employment discrimination and health insurance. On long term, some patients are affected when their employers are aware of their genetic predisposition. It could impact their job security and career progression. While health insurance, they can increase their premiums or they can even face difficulties obtaining coverage in the future. In conclusion, while newborn genetic screening offers significant benefits, we must also address the associated challenges. These challenges include potential psychological impact on children, ethical concerns, resource allocation issues, and societal implications. Firstly, we need to consider the potential psychological impacts on children. Awareness on their genetic conditions from an early age can lead to anxiety, stress affecting their mental and emotional well-being. Secondly, ethical concerns arise particularly around autonomy and the right to not know one's genetic information. We must respect individual and parental choices in this sensitive area. Thirdly, resource allocation is a critical factor, ensuring that we have the infrastructure and funding to support widespread screening without compromising other essential healthcare services in paramount. Lastly, societal implications such as the potential for genetic discrimination and the need for cultural sensitivity must be addressed. We must strive to create an inclusive system that respects diverse cultural perspectives and protects individuals from discrimination. By carefully considering these factors, we can implement responsible and sustainable screening programs that maximize benefits while minimizing harm. Thank you so much for your attention, and I welcome any questions for further discussion on this important topic.